Okay, I think we're at the hour, ready for the next lecture. So thank you so much for coming back to spend some time on this next topic. This is going to be a brief discussion about the potential benefits of cannabis for therapeutic purposes. And just in terms of my disclosures, I am the Associate Director for the Michael D. DeGroote Center for Medicinal Cannabis Research. I do hold grants from CHR to study the effects of cannabis, primarily on chronic pain, and I have no for-profit relationships to declare. In terms of my background, I'm a professor in the Department of Anesthesia here at McMaster University, and I spend a lot of my time looking at different modalities for the prevention and management of acute and chronic pain. So we've heard this morning about the complicated history that cannabis has had in terms of becoming available as a potential therapeutic product. And it has been legal in Canada for select medical conditions since 2001, but it was generally fairly difficult to acquire until a number of legal challenges took place that has increased the access and availability. And licensed healthcare professionals can provide authorization for patients to acquire cannabis for therapeutic use. And of course, since October of 2018, cannabis is available for non-therapeutic use as well. And so it is quite easy for individuals to acquire these products for whatever purpose they deem for themselves to use. So how has this increasing availability affected the number of Canadians that are authorized to use cannabis for medical purposes? Well, in 2015, Health Canada recorded approximately 24,000 Canadians with authorization to access medical cannabis. This could mean that they were permitted to grow it for their own purposes, or they were permitted to acquire it from a dispensary for therapeutic purposes. And that number grew quite a bit by September of 2020. So really just looking forward about 5 years, that 24,000 Canadians had grown to just shy of 380,000. So quite a dramatic increase. But in the intervening 3 years, we can see that that number has started to dip. And in fact, as of March 2023, the number of Canadians that were authorized to access cannabis for therapeutic purposes was about 213,000. And it's interesting to try to understand why has there been this dip. We're not sure. But there is a longitudinal cohort of adults in Hamilton that is being followed. And amongst these, there are a number that do use cannabis for both therapeutic and non-therapeutic purposes. And we thought it would be interesting to look at the declared rationale for using cannabis before it became legal for non-therapeutic use, and then after it was legal for non-therapeutic use. This is a small subset within the cohort, but 6 months before legalization of non-therapeutic cannabis, there were 254 individuals that were declaring therapeutic use. Amongst these, about 1 in 5 were exclusively using for therapeutic purposes, and the majority were what we call dual users. They endorsed use for therapeutic purpose, but also some use for non-therapeutic purposes. And when we went back and surveyed this same group of 254 individuals 6 months after legalization in Canada for non-therapeutic purposes, about 1 in 4 of these individuals sort of changed their declared use. So amongst those that were pure medical users before it became legal to do otherwise, 24% declared they were now dual users. So yes, they continued to use for therapeutic purposes, but they also acknowledged that there was some non-therapeutic use that they were doing as well. And amongst the much larger group that had declared dual use prior to it become legal to use for non-therapeutic, a full 24% advised after it was legal that they were only using cannabis for non-therapeutic reasons. So it seems at least possible that some individuals in Canada were acquiring their cannabis through the only legal means that was available before October 2018, and therefore had maybe perhaps come on the registry as being authorized for therapeutic purposes. But when cannabis became more widely available for both therapeutic and non-therapeutic use, some individuals may have left that system, no longer needing the authorization to acquire cannabis for themselves. So the question is, what is the perception out there regarding benefits of cannabis as a therapeutic agent? And there was a national survey done in the US a few years ago. They reached out to a little over 16,000 adults. And interestingly enough, they found that 81% of respondents believed that cannabis has health benefits. About 1 in 10 believed that there were no risks associated with use of cannabis. 7% believed that it was somewhat or completely safe to use cannabis during pregnancy. And about 1 in 5 believed that you could not become addicted to cannabis. Now, of course, we know that cannabis, as any other potential therapeutic product, is associated with potential risks. There is certainly a reason to believe that there are potential risks for use during pregnancy, and you can develop a cannabis use disorder. So this survey would suggest that there is somewhat of an over-enthusiastic view towards the risk-benefit profile of cannabis. And the same investigators recently released an updated analysis of some of the data. And again, out of this survey, the majority of those that chose to respond had used cannabis in the past year. And when they broke down the results according to overall perceptions and then the larger group that had endorsed use of cannabis, again, about half of those that responded believed that there was either no risk or only a slight risk to smoking cannabis daily. And amongst those that endorsed use in the past year, it was close to 90% that endorsed this. There was about 38% of overall respondents that believed use of edible cannabis was not only therapeutic in terms of managing problems, but could prevent health problems from occurring. And if you looked at the group that had endorsed use of cannabis in the past year, that figure rose up to 61%. Looking at the effect of daily cannabis use on relationships with friends and family, 22% of overall respondents felt that it had no effect on these relationships. 8% actually felt that it improved those relationships, and those numbers went up quite a bit if you look at the individuals that endorsed use of cannabis in the past year. So again, a little bit more of a nuanced analysis. Those that were already using cannabis had even more enthusiastic beliefs and perceptions about potential benefits, and a lack of concerns about harms. But again, a very enthusiastic view towards the potential benefits of cannabis. So what are areas that cannabis might provide some benefits in terms of what the evidence can tell us? Well, one source of evidence that we have is to go to websites. And very often when we speak to individuals that are using cannabis therapeutically, because this is a topic that is not part of undergraduate medical education, because many physicians are not comfortable talking about this, they will often go to the internet and they'll see what other sites have to tell them about this. So I did the same thing. This is a website maintained by an American physician who is fairly enthusiastic about the potential benefits of cannabis. And he had taken the time to compile a list of clinical conditions that he believed cannabis would be helpful for managing. So this is the first part of that list. We've got a number of different viral infections and Lyme disease, some cancers. He goes on to talk about obsessive compulsive disorder and alcohol abuse, anorexia nervosa, amongst others, migraines and Bell's palsy, temporomandibular joint syndrome, gastritis, peptic ulcers, going on even further to a number of different conditions, various arthritis, multiple joint pains. It continues to go on, nausea, diarrhea, chronic fatigue syndrome, ankle and foot injury. Anyways, I ran out of room to sort of keep putting these down, but as you can see, for a patient to go and find this site, it would not be unreasonable for them to come to the conclusion that there was a very large number of clinical indications for which cannabis might provide assistance. But there is a competing view. Not everyone has the same enthusiasm as this physician. And there was an article that came out in the Wall Street Journal by a respirologist. And I think the title is fairly straightforward and conveys their opinion. But this clinician wrote that medicines have research behind them, enumerating their benefits, characterizing their harms, and ensuring that the former supersedes the latter. And they felt that this was not the case for the evidence underlying cannabis. They felt it was largely established as a toxin. It had the ability to impair judgment in driving, increases risk of psychosis and schizophrenia, and has, when inhaled, the potential to damage the respiratory tract. So we have some very, very divergent opinions out there, which you can find by a quick search. Either tremendous enthusiasm for the application of cannabis across a wide range of conditions, or a position where it simply does not have therapeutic potential. Well, what can the evidence from the peer-reviewed literature tell us about this? Well, one thing that's been done is there's been a number of states in the US that have legalized cannabis, and they've been collecting data before cannabis was legal to access and then afterwards. And in some cases, they've noticed that there is a decrease in the use of prescription drug use after cannabis becomes legal. And this is not universal. This is not always the case, but there have been a number of observational reports that have found this. And in particular, they see decreases in the use of prescription medicine for anxiety disorders, depression, nausea, pain, disordered sleep, or muscle spasticity. And this suggests the potential that some individuals may be substituting cannabis for these prescription medicines because they perceive that there is a benefit. So this has given rise to an interest in exploring therapeutic potential in these areas more thoroughly. And perhaps the area where this has been done to the largest degree has been in the exploration of the use of cannabidiol to treat certain pediatric seizure disorders. And there was 2 very well done trials reported in the New England Journal of Medicine. This led to FDA approval for the first prescription drug made directly from a plant extract of cannabis. This is Epidiolex. So this is available for therapeutic use in the US. They are going through the process to authorize use in Canada. And so there is some evidence in this area of a therapeutic potential that has been done in the way you would expect to see any therapeutic agent tested in rigorous randomized trials. And it's now been approved. Well, what about other areas? Well, given the benefits on these certain pediatric seizure disorders, there was a great deal of interest in trying to see if there might be some benefits for patients living with multiple sclerosis. This is a Cochrane review, which came out last year. And they did conclude that there was evidence that compared to placebo, that nabiximols probably reduced the severity of spasticity in the short term. But they were uncertain about the effect on chronic neurologic pain and health-related quality of life. So emerging evidence, promising signal, more work to be done. What about psychiatric disorders? Again, we certainly have heard there are concerns about adverse effects, potential to result in psychosis or even to spark the onset of schizophrenia. Well, there is some literature out there on this, but it's not particularly of high quality. There's been some isolated studies providing, and they say very tentative support for cannabinoids, predominantly cannabidiol, for potentially reducing social anxiety. And then interestingly enough, mixed evidence for adjunctive use in schizophrenia. But again, this is coming from small observational studies, case reports. The evidence is not conclusive. So again, they also felt there was some very, very preliminary signal for potential benefit for sleep and post-traumatic stress disorder, but they acknowledged that the quality of that evidence was currently weak. We, after this review came out, we took a little bit more of a deep dive on exploring for the impact on sleep, and we did find a number of randomized controlled trials that had looked at sleep as an outcome. No trial looking at primary sleep disorders. The previous review that I put up found that to be the case, but we looked at any study where they had looked at sleep as an outcome, either sleep disruptions or quality of sleep. And again, we did find moderate certainty evidence that different formulations of cannabis for therapeutic purposes or individual cannabinoids did show some improved benefit on both disordered sleep or the quality of sleep, but the magnitude of the benefit was fairly small. You typically needed to treat around 15 or so patients before one would report an important benefit. And this is versus placebo. So some evidence, and again, more work needs to be done. We didn't find any trials looking at a primary sleep disorder. This is an area where there's been a great deal of anecdotal support. Certainly, this was an area where there was a lot of authorization for use of cannabis on compassionate grounds. Individuals that were living with cancer, and as a component of their therapy, they were dealing with reduced appetite. They wanted to try to increase that. This is a systematic review looking to see the definitive evidence that we have that cannabis might be helpful in increasing appetite amongst individuals that are under treatment for cancer. And again, they weren't able to make any firm conclusions. They found observational data, low certainty. They acknowledged that there was a lot of anecdote out there, that there could be a potential, but also that the strength of the evidence did not currently allow them to make a strong recommendation. And again, it's difficult to study therapeutic benefit of products that have the history that cannabis does as an illicit substance. But again, there's some evidence to suggest potential benefit, but this message that more research is needed continues to come up. There's also a review that came out a few years ago looking at the evidence to support use of cannabis for individuals living with inflammatory bowel disease. And they did not find evidence that cannabis could cause remission of IBD or that it had particular impact on inflammation, but they did find some consistent signal that patients reported reduced symptoms associated with IBD and improved quality of life. So again, appears to be promising. And when we look at how individuals are using therapeutic cannabis products, this is an assessment of administrative data in the United States, where they looked at over 800,000 adults that were licensed to use cannabis therapeutically. This is in 2017. And it's quite clear from this graph that chronic pain is the dominant qualifying condition for which patients are accessing these products. You know, there's lower rates of use for things like multiple sclerosis or epilepsy, chemotherapy-induced nausea and vomiting, even PTSD. But chronic pain is by and large the dominant primary indication. So given that this is what it is primarily being accessed for, it's quite reasonable to look at the evidence in this area. And there was a guideline that came out from the UK National Institutes for Healthcare and Excellence, and they looked at this topic. They made a strong recommendation against the use of cannabis for chronic pain. The International Association for the Study of Pain also reviewed the literature. A few years ago, they made a statement that due to a general lack of evidence from high-quality research, They did not endorse the use of cannabinoids to treat pain. So we have an interesting situation now where we see that the dominant purpose for use of therapeutic cannabis appears to be in the area of chronic pain. We have two international organizations, well, one case international, one case national, making fairly strong statements that there is not really an endorsement in this space. So it's of course appropriate to then ask if patients should be steered away from this indication. And we decided to look at this more carefully. So in particular, our question was in adult and adolescent patients living with chronic pain, either due to cancer or non-cancer causes, should we be recommending a trial of cannabis for therapeutic purposes or cannabinoids versus continued care without? And we set up to look at this question, to synthesize the evidence, and then to enable a guideline panel to make a recommendation. And the recommendation could be against the use of medical cannabis, or it could be in favor. And we use something called the grade approach to formulate our recommendations. With the grade approach, you can make a strong recommendation if the evidence shows a clear imbalance between the benefits and the harms. Either the benefits clearly exceed the harms, in which case it would be a strong recommendation in favor, or the harms clearly exceed the benefits, in which case you would make a strong recommendation against. We have to have sufficient confidence in the quality of that evidence, either moderate or high certainty evidence for those effects. And evidence alone is not enough to make clinical decision-making. We also have to understand patient values and preferences. So we would have to have an indication that if given the evidence for benefits and harms, that essentially every patient would make the same decision. And if each of these criteria are met, we can make a strong recommendation. Now, if they're not, we are left to make a weak recommendation, or what we call a conditional recommendation. We do these when there's a close balance between the benefits and harms. It's not so obvious. And we need then to understand what patients value more. Do they value the potential for the benefits, or do they value the potential for harms, given that they're fairly close? We could also make a weak recommendation in the presence of low certainty evidence. The lower certainty tells us we're not sure what the effects are. And we would also make these weak or conditional recommendations if we understood that given this information, different patients are likely to make different decisions. So these are the two types of recommendations that we can make, and they're based on the relative magnitude between the benefits and harms, the certainty of evidence, and patient values and preferences. Now, we took a patient-centered perspective for this guideline. We had 21 members that were on the guideline panel. These included clinical experts, methodologists, 3 patient partners living with chronic pain, and none of the guideline panel members could have any financial or important intellectual conflicts of interest. We wanted them to be able to come into this with an open mind, able to look at the evidence and the information, and to make objective recommendations on that material. So we began by exploring patient values and preferences. So we did a systematic review on this topic. And we were interested to understand the relative importance or values of outcomes related to medical cannabis use. Again, what value do people living with chronic pain put on the potential benefits, pain relief, functional improvement? What value do they put on potential harms that we understand could be associated with cannabis? We wanted to understand attitudes and preferences for or against medical cannabis as a therapeutic agent, different modes of administration, different formulations for managing chronic pain. And we wanted to understand what factors influenced patients' decisions, whether they would be interested or disinterested in a trial of therapeutic cannabis. So we found 15 studies eligible for this review. They all reported the values and preferences of patients, of adults. Most of these studies enrolled patients from the US, but we did have representation from 4 other countries, including 1 Canadian study. And they were all fairly recent, conducted in the last couple of decades. And both cancer and non-cancer patients were represented. So we found moderate to high certainty evidence that many patients valued the effectiveness of medical cannabis for symptom management, even when they experienced adverse events related to concentration, memory, or fatigue. We found that people using for therapeutic purposes had a greater preference for products that either had high levels of CBD or balanced ratios of THC to CBD versus high levels of THC. So this was different than pure recreational users. We found that their decision whether or not to attempt a trial of cannabis for their pain was influenced by both positive and negative social consequences. Cannabis, as we heard in this morning's lecture from Dr. McKillop, is a product with a long history, certainly with a lot of stigma attached to it. And there's awareness about this, and it affects people's decisions whether or not they're interested in using it. We found that patients indicated concerns about medical cannabis, in particular side effects such as addiction, tolerance, losing control or acting strangely, and that patients that had higher value regarding these adverse events were much less willing to consider a trial of cannabis. We found low certainty evidence that there was variable attitudes towards the use of cannabis amongst people living with chronic pain, and that patients in many cases appeared motivated to use cannabis as a strategy to reduce their reliance on prescription medication and felt that it was a safer alternative than opioids. So that's what we learned from our values and preference information. Interestingly enough, neither the NICE guideline or the IASP work reported any systematic attempt to explore patient values and preferences. And we did publish this work recently in BMJ Open. Now, we understand something about values and preferences. We then wanted to look at the evidence for both benefits and harms. And we started off looking at randomized controlled trials. And we found 32 eligible trials. We looked at any study in which cannabis or a cannabinoid was administered against any competing agent for the management of chronic non-palliative pain, as long as they followed patients for at least 1 month. We didn't think that the results of a few hours after administration was particularly helpful to patients. We found 32 trials that met this criteria. Most were on chronic non-cancer pain, but 4 were on patients with chronic cancer-related pain. All adult populations, median age 54. Length of follow-up, it was at least a month. That was our eligibility criteria, but it didn't go particularly long. The longest study followed patients only for 140 days, so fairly short follow-ups in these trials. Unfortunately, placebo was the most common control. That was in all but 3 studies. In terms of the types of cannabis, predominantly it was plant-derived cannabinoids, but also a fairly good representation of synthetics, and a handful of studies looking at endocannabinoids. Modes of administration, gel-filled capsules or sprays were really the dominant form of administration. 1 study looked at sublingual drops, 2 administered transdermal creams. Interestingly enough, no eligible trial explored inhaled forms of cannabis, which we know is a fairly common mode of administration, whether through smoking or vaporizing. So this is a fairly busy table, but the most important thing to focus on is the part that I've indicated in red here. So the first column here looks at the different outcomes that we captured, and we looked at all patient-important outcomes. We report the range of follow-up of trials that inform the evidence for each of these outcomes. And then we looked at the treatment effects. Now, we did look at average effects, but I really want to focus on the risk difference for achieving what we call the minimally important difference. The minimally important difference is the smallest amount of improvement that patients indicate is important. And what's interesting to note is that if we look at the, the first outcome is pain relief. So very important outcome if you live with chronic pain. And amongst the 1,300 patients that were allocated to the cannabis arm amongst the 27 trials, 62% of patients reported an improvement in pain that met the minimally important difference. However, if you look at the placebo arm, the number is quite high as well. It's about 1 in 2 patients noticed an important improvement in pain with receiving placebo. So the risk difference, or the added proportion of patients that achieved important benefit, was 10% with use of cannabis. So it's not a large effect, but chronic pain is a very challenging condition to treat. This means you would have to treat about 10 patients with therapeutic cannabis versus placebo to get 1 additional patient that will report an important benefit. Now, we did have some inconsistency in this pooled result. We had some studies suggesting a larger effect, some smaller. So we did rate down 1 level for that inconsistency, but we still concluded moderate certainty evidence for this modest but potentially important benefit on pain. When we look at physical functioning, we also found a statistically significant benefit. We had high certainty evidence for a very small increase in the proportion of patients that were likely to achieve an important benefit in physical functioning. Risk difference of 4% means you have to treat 25 patients with cannabis versus placebo for 1 to experience an important improvement in physical functioning. And we found high certainty evidence there was not an effect on emotional functioning. Now, what did the NICE guidelines say about the effects on pain? Well, they concluded that the treatment effect was modest, but it was actually fairly certain to the average effect that we found. They found a mean difference of about 0.44 on a 10-point scale. That was by pooling 11 studies. We considered quite a few more. We had 27 trials. But again, our average effect, our weighted mean difference, was quite similar to theirs. They had negative 0.44, we had negative 0.5. The question is, why did they conclude that this effect was unimportant? That allowed them to make their recommendation against use of cannabis. Well, the reason is they only focused on this average improvement in pain, which is a little bit like taking the average height in a room of people and concluding that everyone is that height. We know that there's variability in treatment response with any therapeutic agent for the management of chronic pain, therapeutic cannabis being no different. So yes, the average effect is quite small and does go below the minimally important difference, but we took the extra step to calculate the proportion of patients that would actually achieve an important benefit. And that ended up being, as I've shown in the previous slide, about 10%. So we don't hold that everybody will achieve an important benefit with cannabis, but we do hold that about 1 in 10 patients will. And so we didn't just focus on the average, we focused on the proportion. And then, of course, it's up to our panel, knowing what they know about patient values and preferences, to understand if that's likely to be a large enough improvement, large enough chance of improvement that patients might be interested. What did the IASP work, the International Association for the Study of Pain, say about the effects of therapeutic cannabis on pain? Well, what they concluded is, yes, there was an effect, but they discounted it because they said it's very low certainty due to risk of bias. So they said we don't trust these estimates, even though they show the potential for benefit. And we also looked at risk of bias, and true, we did find that only about 2 out of 3 adequately generated their randomization sequence, or at least reported that they did. And we found that about half of the trials had a high proportion of missing outcome data. So we also found risk of bias issues, but we did something a little bit additional. So instead of concluding that the evidence was not believable, we looked to see what the impact of this risk of bias was. Again, a risk of bias is simply that. It doesn't mean that the bias was realized. it means it might have been realized. So we can look at this by doing a subgroup analysis, for example. What we can do is we can take the trials at low risk of bias, and we can see what kind of treatment effect they report. We can look at the studies at high risk of bias and see what kind of treatment effect they report, and see if there's evidence for a credible subgroup effect. And what we find for the trials at low risk of bias is they actually, if we pool just those studies, it increases the effect on pain relief. It goes from 0.5 up to 0.74. The trials at low risk of bias actually report a much smaller effect on pain relief. But when we look to see if there's a credible subgroup effect, our test of interaction is non-significant. So again, if we believe that risk of bias was affecting the results, and we only considered trials at low risk of bias for adequate randomization, we would have concluded that cannabis had a larger effect on chronic pain. But because the interaction was not significant, we pooled the studies together and we said we do not have evidence that risk of bias is realized here, so we're not going to rate down for this issue. What about loss to follow-up? Well, for this, we did something called a meta-regression. And in here, each of these circles represents a randomized controlled trial. On this axis, we have the proportion of loss to follow-up. On this axis, we have the degree of pain relief. So again, this is on a 10-point scale. 0 means there's no pain relief. Here's -1 point. Here's -2 points. And what we can see is studies that have higher loss to follow-up actually are reporting systematically less pain relief. So once again, we're in the situation that if we don't believe the studies with higher loss to follow-up, we would end up concluding that cannabis had a larger effect on pain relief. But again, we did not find that this was credible. So we pooled the studies together, and we did not rate down for risk of bias due to missing outcome data. So this is what allowed us to keep a higher rating in the certainty of evidence than the IASP did, because we assessed the impact of risk of bias instead of reporting that there appeared to be a potential issue with that risk of bias. What about other outcomes? Well, if we look at role physical or social functioning, we have high certainty evidence that there is not a difference between the people that were randomized to receive cannabis or placebo. When it comes to sleep quality, we did find evidence of a modest but significant improvement. We had high certainty evidence for a risk difference of about 6%. And what this means is that you have to treat about 17 individuals with cannabis versus placebo for one to note an important improvement in their sleep quality. In terms of reduction of opioids, and again, you recall this was in the values and preference literature, one of the areas that patients were interested in. We found 4 randomized controlled trials, as did the UK NICE guideline. And when we pooled these, there really was no difference in terms of the amount of opioids that people randomized to cannabis versus placebo were using. And it was on this basis that the UK NICE guideline concluded that there was no evidence to support a substitution effect to allow patients to reduce their use of opioids. However, in this case, we rated our certainty in this as very low. Why did we rate it as very low when the UK NICE guideline took this as evidence that there was no substitution effect? We did this because all 4 trials that reported this outcome were enrolling patients with cancer-related chronic pain, and they instructed patients in these trials not to do any changes to their use of prescription medications during the trial. So yes, there was no difference at follow-up between those randomized to receive placebo or cannabis, but they were instructed not to change their dose of opioids. So we really felt that this was very problematic evidence. It did not give us confidence in the results. So what we then did is we looked to observational data. And we found 6 observational studies that enrolled 710 patients. And in these studies, when individuals were given access to therapeutic cannabis, they did significantly reduced their use of opioids, an average of 20 milligrams morphine equivalent per day, which is a fairly substantial amount. Now, again, because this is observational data, we rated our certainty in that evidence as very low. But what we ended up concluding was we are really uncertain as to whether or not use of cannabis will allow patients to reduce their reliance on opioids, but we certainly cannot make any conclusion that it does not have a substitution effect. Again, we published this last year. Now, I've told you about some of the evidence we have for benefits. We also have to talk about harms, of course. And when we look across the harms that were reported by trials, whether it's cognitive impairment, vomiting, drowsiness, we did see evidence for a significant increase in these harms for patients randomized to receive cannabis versus placebo. But the risk differences also tended to be fairly modest. So cognitive impairment, the risk difference versus placebo was 2%, meaning you'd have to treat 50 patients for one to experience this important harm over placebo. Risk difference for vomiting, 3%. Risk difference for drowsiness, 4%. So there is a significant increase, but again, it's quite modest. Dizziness was the one where we saw a larger impact. We found a subgroup effect based on duration of treatment with cannabis. For patients treated for less than 3 months, the risk difference was 8%. But when you get into longer periods of treatment, greater than 3 months, about 1 in 3 patients versus, an additional 1 in 3 patients versus placebo would report at least one episode of some dizziness during the trial follow-up. Impaired attention, diarrhea, nausea. Again, yes, there was evidence for an elevated risk for those receiving therapeutic cannabis, but again, the risk differences tended to be fairly modest, ranging between 3 and 5%. And this was all moderate certainty evidence. And we did publish this as well. Now, what about more serious adverse events? Well, we didn't find them reported in randomized trials. So for this, we had to look at observational studies, and we found very limited information because we focused on therapeutic cannabis. We did not focus on recreational cannabis. But we, looking at things like cannabis dependence, road traffic injury, falls, suicide, suicidal ideation, very low certainty evidence, not enough for us to understand if there is an increased risk or not for these outcomes for individuals that are using cannabis therapeutically for the management of chronic pain. If we're going to make a recommendation, we have to look to see what kind of patients were enrolled in the studies that we derived evidence from. And again, none of the trials eligible for our review explored the effect of inhaled forms of cannabis, and none of them enrolled patients involved in palliative care. So our recommendations are not able to extend to these populations. And they largely excluded patients with chronic pain that had comorbid mental illness or were receiving disability benefits involved in litigation. So the generalizability of our recommendations to those important populations is uncertain. They may have a different prognosis than the patients that were included in these trials. So again, looking back at the GREAT approach for formulating recommendations, do we have a clear imbalance? Evidence that the benefits clearly exceed the harms or the harms clearly exceed the benefits? I would say no. We appear to have evidence for the possibility of modest benefits. We also have potential for modest harms. So fairly close alignment. We do have sufficient certainty in the benefits and the short-term harms. So that we could probably say yes, although the long-term more serious harms, the answer would be no. And in terms of patient values and preferences, from the work that we did and also from the feedback on the 3 patients that helped on our panel, we found evidence to suggest patients are going to have fairly variable views on whether or not they're interested in cannabis, and variable views in terms of whether they value the potential benefits more than the harms. Although a lot of patients that were using cannabis did acknowledge that they did place a higher value on the benefits than the harms, which which would make sense since they were continuing to use cannabis. Again, weaker conditional recommendation. I think this is our situation. We have more of this close balance between the benefits and harms, and a fair bit of variability in patients' values and preferences. Are they more concerned about the social stigma? Are they less concerned? Are they more concerned about the potential of some of the harms? Are they place higher value on the benefits? There seems to be quite a bit of variability out there. And so given all of this, our panel ended up making a weak recommendation to offer patients a trial of non-inhaled cannabis or cannabinoids for therapeutic purposes versus standard care alone if standard care had been insufficient. So again, there are a number of interventions for chronic pain that do show evidence of benefit that would be appropriate to try first, but for individuals that have not found sufficient relief with other types of care that are available, our panel felt that it was reasonable to provide patients with the evidence for benefits and harms and to help them make a decision consistent with their values and preferences. So we ended up making a recommendation that was quite different from the other two guidelines that I presented, but I hope that the reasoning for why we ended up here makes sense in terms of what we did compared to the other guidelines. Now, what was interesting is last month there was a viewpoint that was published in JAMA Psychiatry, and what they did is they referred to the evidence synthesis that was used by the IASP to basically reiterate their conclusions, right? The IASP said, oh, there was very low certainty evidence, so we really can't endorse use for chronic pain. And so they made that conclusion as well. They said the current body of evidence does not support the use of cannabis for the treatment of pain. I thought it might be helpful to write a letter to the editor about this, so I did so. And I advised that whereas the IASP did explore for the possibility of risk of bias, they didn't see if that affected treatment results. We had done so and found there was no credible subgroup effect. And in fact, if we had believed that risk of bias was a problem and we only looked at the studies at low risk of bias, the effect of cannabis on pain would have been larger. I also indicated that this review that they had chosen to focus on was actually older than two subsequent reviews. There was the one that we had published in 2021, and there's this review that came out in the Annals of Internal Medicine after ours. This came out in 2022. And essentially had the same finding that there was moderate certainty evidence that cannabis was able to provide sort of modest but potentially important relief for chronic pain. And I highlighted the guideline that demonstrated that when this evidence had been considered of a panel in context of values and preferences, that there was an evidence base to consider a trial of cannabis for individuals in whom standard care was not sufficient. And the editors wrote back to me and said, thank you for your letter, but we are not going to publish it. So, I think the stigma around use of cannabis as a therapeutic agent, even for indications where it's commonly used and where there does appear to be an evidence base to draw upon, there's still a challenge out there, I would say. So in summary, the evidence is emerging. There's a lot more to do, of course. But CBD has now been established as showing modest benefits for certain pediatric seizure disorders. There is emerging evidence that cannabis may be helpful in reducing spasticity associated with multiple sclerosis. It may help chemotherapy-associated nausea and vomiting. Not sure if it helps increase appetite. There's just anecdote and some case studies at this point. But it may improve symptoms and quality of life amongst inflammatory bowel disease patients. And it appears to provide modest benefits for a minority of patients living with chronic pain in terms of reducing their pain, possibly increasing their functional capacity and improving their sleep quality. For other conditions, there's certainly a lot of anecdote. There's certainly a lot of very enthusiastic information on the internet. But the evidence for the effectiveness of therapeutic cannabis remains uncertain and important areas of study. And a lot of this has actually recently been concluded by a large umbrella review that just appeared in the British Medical Journal about a week ago. So timing is great. I would encourage anybody that is interested in sort of an overall synthesis of the evidence for both the benefits and the harms of therapeutic cannabis to review this paper. I think it's done a very comprehensive job looking at both randomized trials and observational studies. And with that, I'd like to thank you for your attention, and I'm very happy to take any questions.
Thank you, Jason. So once again, if you have questions, please type them into the Q&A box and I will read them out. Question from Dr. Amy Thiel. Did you say that these studies for chronic pain were looking at CBD only, or CBD THC combos, or just THC?
Yeah, great question. And, I would encourage people to look up the review that we published. So most of the studies were looking at CBD THC combinations. There were 2 studies that only looked at CBD, and we wanted to do a subgroup. Well, we did attempt a subgroup analysis to see if we could explain the variability and treatment effect based on the composition. That's of course an excellent hypothesis. We weren't able to find evidence of a credible subgroup effect, but we just didn't have enough variability in the products to be confident about that. We are trying to, we have updated this. We're trying to get a hold of individual patient level data to sort of, look at this more carefully. But right now, again, the kinds of products that were administered, there were no THC in isolation. It was combination products almost entirely. A few studies looking at CBD only. There was also a few looking only at endocannabinoids, but we just didn't have enough power to be able to be confident about a subgroup effect based on composition, although you would certainly imagine that could be important.
Next question from Nicole Dimitrova. Do you think that the route of cannabis administration matters for pain relief?
Well, a real limitation of our initial guideline, which was sort of very focused, was that we didn't find evidence on inhaled forms. That was a big limitation. I do think it's important. We know, for example, that if you inhale cannabis, you get a much quicker mechanism of effect. It might not last as long. You're also taking on additional potential risk to lungs and pulmonary harms. We know there's a number of topical preparations. We don't have great pharmacokinetic data demonstrating that there's good penetrance past the aqueous layer of the skin to actually get to the site that you want. So I do think that the mode of administration is potentially an important source of variability and responsiveness to cannabis. And I do think it was an important limitation that we were unable to find evidence on inhaled forms of cannabis for the work that I've just presented, because we know that many individuals that live with chronic pain are either smoking cannabis or vaporizing cannabis. And what I will say, and I'll be speaking about this later on in the conference, is we've recently completed an update and a more expansive exercise to come up with clinical guideline recommendations for cannabis and chronic pain, where we have looked at any information we could find on inhaled forms. And so I don't want to get ahead of myself, but I will be presenting the evidence that we found for that a couple of days from now.
Any final questions for Jason? Another one. Amanda DeConnick. How did the studies that looked at endocannabinoids for pain relief measure endocannabinoid levels? And how would one use ECB? How would that be used as a treatment for pain?
Yeah, so we did find, so again, we have detailed information on the sort of dose and amounts and the types of, PEA was sort of a commonly administered endocannabinoid. And we went to our clinical experts on the panel, and we had a lot of debate as to whether or not we should even consider endocannabinoids within our review, or should we exclude them. So there have been a small number of studies where they have administered these products. I will say that again, when we looked at a subgroup analysis based on type of cannabinoid, there was a signal that the endocannabinoids might be less effective, but again, because small numbers of trial, very imprecise effects, we weren't able to sort of conclude with certainty that they were less effective, even though there was a trend in that direction. So again, I can't recall off the top of my head the sort of particular doses that they were using. We do have the information in our systematic review, though, and it's available open access online, but I'm happy to send it to anyone who would like to look at that more carefully. And again, they have been used therapeutically in the context of randomized controlled trials. Some signal that they might be less effective than synthetics or phytocannabinoids, but the data is too limited for us to be confident in saying that there is a difference in effect.
All right, last question from Joseph in Ottawa. Hi, Jason. Thanks for a great presentation. Overall, from your systematic reviews, can you say if there was a dose-dependent effect of THC and CBD, THC-CBD combo on treatment efficacy? Also, is there a dose effect on AEs, i.e. the higher the dose, the higher the AE?
Yeah, so we did find some evidence to suggest that the adverse effects were really more associated with products that had THC versus the ones that had CBD only, or the ones that were only focused on endocannabinoids. So certainly, if we're talking about the harms, you're looking, with the kinds of doses that are typically given for chronic pain, you're going to see more of that association, in some cases, all the association with products that contain THC. If you look at other clinical areas, these sort of pediatric seizure disorders where they use very, very high levels of CBD, you can see some adverse effects associated with that. But when it comes to chronic pain, the doses that you're using, there does appear to be an important issue around, well, what are you taking? More THC, higher risk of adverse events. If you avoid the THC, you really seem to move away from the adverse events, at least as far as what we saw. I do think that the dose is probably critical. The challenge we had with many of these trials, they almost all allowed for post-randomization titration by patients. So they would start patients off and say, if you're, whatever group you're randomized to, you have the leeway, you have the ability to either up your dose or decrease the dose after you've been randomized till you find an amount that seems to work well for you. This makes it very difficult, as you might imagine, to do a dose response meta-analysis because of the post-randomization titration. We are looking at getting individual patient level data from these trials where we are hopeful that we're going to be able to get specific doses per the individual and then facilitate that kind of analysis. Because you would imagine that if these products have an effect, then there must be some issue with the dose. There's going to be a balance that patients get to for those that find a benefit where they reach a dose where that benefit is okay for them, but it's not getting into the point where the harms are overly problematic. So we couldn't do that work with the aggregate level data meta-analysis, but we're hopeful to be able to do it if we can get our hands on the individual patient level data.